Hello, I'm Dr. Vladimir Maletic. I'm a clinical professor of psychiatry at the University of South Carolina School of Medicine in Greenville, South Carolina. Welcome to episode 2 in a series of 4 podcasts on bipolar depression entitled Mechanisms of Actions of Novel and Emerging Treatments for Bipolar Depression. It is now my great privilege and honor to introduce to you my esteemed colleague, Dr. Leslie Citrome, who is a clinical professor of psychiatry and behavioral health at the New York Medical College in Valhalla, New York. Welcome, Liz.
Well, thanks, Vlad. Happy to be here.
So, Les, I know you have conducted so many analyses and meta-analysis and are probably one of the most knowledgeable, both nationally and internationally, experts on treatment of bipolar disorder. So, if you wouldn't mind giving us a quick overview of the available agents to treat bipolar depression and maybe address their mechanisms of action.
Happy to do so. There are actually only 5 FDA-approved treatments for bipolar depression, and they're all foundationally second-generation antipsychotics. So we expect them to block in some way dopamine D2 receptors, either as a full-on antagonist or as a partial agonist. One of them also is combined with fluoxetine. That's olanzapine fluoxetine combination. So let's start with that one actually. OFC was the first agent ever approved for bipolar depression about 20 years ago. It's approved for bipolar type 1 depression and was tested in psychotic depression. It's also approved for pediatric populations. It was not tested in combination with lithium or valproate, but it is the oldest one out there and the very first one. So that introduced us the idea that it takes a second generation antipsychotic to treat bipolar depression. And it came along with the observation that SSRIs and SNRIs and whatnot are not efficacious in bipolar depression. So we needed a different way of addressing this problem. Quetiapine immediate and extended release were also approved for bipolar depression, bipolar type 1 and bipolar type 2. They're different. Quetiapine IR and XR is different than olanzapine in some of the receptor binding affinities and is associated with a different side effect profile, particularly greater degrees of sedation. Quetiapine was never tested in psychotic depression, nor was it tested in adjunctive use with lithium or valproate or in pediatric populations. And for a while, those were the only two available. Lurasidone was approved about 10 years ago for bipolar type 1 depression, either as a monotherapy or adjunctively with lithium or valproate. It was not tested in psychotic depression. It is approved in pediatric populations. It is now generic. Lurasidone has a different receptor binding profile than olanzapine fluoxetine combination or quetiapine, rendering it more metabolically friendly, but associated with some degree of akathisia. By and large, we were happy with lurasidone for a long time as it provided some additional benefit with better tolerability, and we'll get into that in a few moments. Cariprazine and lumateperone are relatively new additions to our armamentarium for bipolar depression. Cariprazine approved in 2019, lumateperone in 2021. Cariprazine is approved for bipolar type 1 depression. It was not tested in psychotic depression and not assessed for adjunctive use with lithium or valproate and not approved for pediatric populations. Cariprazine is different from lurasidone, quetiapine, and olanzapine fluoxetine combination as it provides us with a dopamine receptor partial agonist as a mechanism of action with a preference for the dopamine D3 receptor, which may have some importance in the control of depression. Lumateperone, the most recent addition to our arrows or quiver in our quiver, so to speak, in terms of what we can use, is approved for both bipolar type 1 and bipolar type 2 depression. It is approved for adjunctive use if desired with lithium or valproate. It has not been tested in psychotic depression, nor is it approved in pediatric populations at this moment. Lumateperone is yet a different mechanism of action. Although foundationally a second generation antipsychotic, it actually has a much greater fold affinity to serotonin 5-HT2A receptors as an antagonist compared to dopamine D2 receptors. It is metabolically friendly and not associated with motor movement adverse events. So it represents yet a different choice. So these five choices that I talked about, olanzapine fluoxetine combination, quetiapine, lurasidone, cariprazine, and lumateperone, although they're all second generation antipsychotics, they do differ in terms of their receptor binding profiles or their personality, so to speak.
Thank you for such a detailed response, Les. I do have one question before we proceed. Some of our colleagues believe that if one medicine with a mechanism of action of a certain type works for bipolar depression, so will other agents in that group. You popularly call them ABCs. Are those agents all equal when it comes to their efficacy in bipolar depression?
Well, that's a good question, Vlad, because cariprazine belongs to those ABCs. I'll spell them out: aripiprazole, brexpiprazole, cariprazine. Although they're all dopamine receptor partial agonists, they do have different affinities at other receptors. And it's not a guarantee that if one in this family works in bipolar depression, that the others would work too. They're sufficiently different. So here we have a conundrum, so to speak. We can have some similarities, and yet when we test them out in people, we can't detect differences from placebo when we test some of these agents. And there's some famous examples of this that we won't go into that we thought would work in bipolar depression, but simply does not. So, as I like to say, the proof of the pudding is in the tasting. And unless you can show something works in a clinical trial, then theoretically, you can talk until the cows come home. It won't matter until you actually see it working in a randomized controlled trial.
I really appreciate you providing that answer for our audience clinicians. Um, so, you spoke about evidence and evidence based medicine. I know that this is a particular area of interest for you. So, can you share with us, as a clinician, how do we apply evidence based medicine when we approach treatment of bipolar depression?
Well, one thing that people must remember is that evidence based medicine is not cookbook medicine. It means taking into account several bits of information in making the best decision possible for your individual patient. So, of course, you're going to take into account the relevant scientific evidence, but you'll also need to use your clinical judgment and the patient's values and preferences in making this decision. Evidence based medicine offers us a framework in which we would use our brains, our patients' brains, and keeping up with new information and making sense of it. And there's some tools that we can use to practice evidence-based medicine. It's called evidence-based practice, and it means being able to interpret clinical trial data in patient terms. Now, keep in mind that a clinical trial will compare groups of people, and we treat individual patients. So keep that in mind when applying this information. But basic to this understanding of what works and what does not work is this concept of effect size. So it's challenging to interpret clinical trial results just based on a p value. And generally, we think of p values of less than 0.05 as being sufficient to say that a treatment would work. And we're inclined to think that maybe a p value less than 0.001 would be even better. But actually, that doesn't really answer the question whether that intervention is better or not. Low p values only tell us we have more confidence that the result we see in a trial is the truth. The lower the p value, the more confident we are that we're dealing with a real effect. But it doesn't tell us the size of the treatment effect. My preference is to express effect size in patient units using the metrics of number needed to treat to describe benefits and number needed to harm to describe outcomes we would rather avoid. Basically, number needed to treat answers the question: how many patients would you need to treat with one intervention compared to the other before you would expect to encounter one additional outcome, positive outcome of interest, such as response? Number needed to harm is kind of the evil twin of NNT and refers to outcomes we would rather avoid. How many patients would you need to treat with one intervention instead of the other before we'd expect to encounter one additional outcome that we would like to avoid, such as weight gain of at least 7%, or an adverse event of sedation, or an adverse event of akathisia. So we can actually use number needed to treat, number needed to harm to describe the approved medications for bipolar depression.
Know that you have provided us with very valuable information about how we can convert efficacy based on trials into clinical context. Can you tell us a little bit about how do we use number needed to treat?
Well, Vlad, we can calculate the NNT, number needed to treat, based on binary or dichotomous outcomes. Did someone respond or not? Did someone remit or not? So, for example, response based on the Montgomery-Åsberg Depression Rating Scale total score would be a 50% reduction from baseline. And I think we would all appreciate someone who has that kind of response and they're readily identifiable. Ultimately, we would want remission with a total score less than a certain threshold, usually 12 or 10 at endpoint. Those are the two basic efficacy outcomes that we can examine with some ease based on the published data, and at the same time consider the harms that may be possible when using an intervention. So, how many patients gained at least 7% of their body weight? How many exhibited sedation or somnolence as an adverse event, or akathisia, or actually any adverse event that would be relevant to them or the clinician being, giving the medicine and is concerned about a specific outcome? You can calculate these number needed to harms too, and you balance it all out. So, for example, we can calculate responder rates by looking to see how many patients responded over how many patients were included. So we have a percentage there. We can do that for the drug, and we can do that for placebo. So I've done that for lumateperone, cariprazine, lurasidone, quetiapine, and olanzapine fluoxetine combination. And I have these two percentages: response on drug, response on placebo. I can then easily calculate NNT, and if anyone is interested in learning how, I'd be more than happy to address this at another time, or they can email me actually. I'm easy to find. And we can calculate the NNTs as being in the range of 4 to 10. And that's desirable in terms of an efficacious treatment versus placebo based on historical clinical trial evidence accumulated over the years. So I would say they all work. The 95% confidence intervals for these NNT estimates all overlap. So I'm comfortable by saying, when comparing groups of people with bipolar depression, that these five interventions approved by the FDA are efficacious. Now, in terms of remission, they also overlap, but there are some other differences that maybe are unexpected. So, when we find outcomes that are not what we think it should be, we need to look at the data. Was the placebo response or remission rate very high, for example? That could be. In modern day clinical trials, there's a lot of support provided to the participant in terms of feeling better. They're in a going to a structured environment for assessments. They're getting paid for their participation. People on placebo will do better, but you would want people on the active drug to do even better than that, and we hope that it's statistically significant. And we can calculate the NNTs in that way and go on from there. If the NNT is, a single digit, we're happy. Now, number needed to harm is the other side of the coin that we need to consider. Here, these drugs are extraordinarily different. So what I've taken to do routinely now is construct heat maps where I have the NNH values for different outcomes for the different drugs, and I put a green box when the NNH is greater than or equal to 20, because that means I will be unlikely to encounter that harm on a day-to-day routine basis. For NNH values between 10 and 19, I consider that intermediate risk, and I put that in yellow. But basically, red is what I'm concerned about the most when the number needed to harm value is less than 10. because that approximates the number needed to treat value for response or remission. And I clearly do not want to encounter the harm as often as I do response or remission. That would be a problem. Unfortunately, that is the case with olanzapine fluoxetine combination and quetiapine. And we've known that for years. For olanzapine fluoxetine combination, we know weight gain of at least 7% is common. The number needed to harm is 6. For every 6 people randomized to OFC versus placebo, you expect to encounter one additional patient with weight gain of at least 7%. That's about as often as response or remission. And for quetiapine, the number needed to harm for somnolence is 3. That means for every 3 people randomized to quetiapine versus placebo encountered an adverse event of somnolence. That's actually more often than encountering response or remission. So those were the drawbacks of the older treatments. So when lorazepam came around, that was much easier to use. Most of the adverse events have a green box on them, meaning you won't encounter them, with the exception of akathisia. But even then, at the low end of dosing, 20 to 60 milligrams a day, the number needed to harm there is 18. So I'm not going to be terribly worried about it. Cariprazine is essentially all green, as is lumateperone, with the exception of somnolence. So we have big differences in tolerability, with the newer agents actually better tolerated, and they're tolerated better also in different ways. So if I have someone who's very concerned about akathisia and weight gain, I'm drawn to thinking about lumateperone, for example, because I can avoid those adverse events more readily than other choices.
We're starting to see some emerging data related to treatment of bipolar depression with mixed feature specifier. Do you have any comments about these more recent studies or any suggestions regarding diagnosis of bipolar depressive episode with mixed features?
1 out of 3 people with bipolar depression type 1 or 2 actually meet this DSM-5 criteria for the mixed feature specifier. That's bad news. They have a higher risk of suicide, a poor longitudinal course, more depressive episodes, more comorbidities, more risk of rapid cycling, and greater risk of inducing mania with antidepressant monotherapy. So we absolutely need clinical trials that examine major depressive episodes with the mixed feature specifier to figure out what would be the best treatment. To my knowledge, there were 2 large trials conducted by industry looking at this. One was conducted in major depressive disorder with the mixed feature specifier looking at lorazepam, and it was successful. And the other was looking at lumateperone for the treatment of both major depressive disorder and bipolar depression with the mixed feature specifier, and looking at lumateperone's efficacy there. And that trial was also successful. So this is good news for us. It's going to point us in the correct direction with these difficult to manage patients.
Les, thank you so much for such a comprehensive overview of treatment of bipolar depression. Uh, Before we conclude our podcast, would you have any other pearls of wisdom that you would like to impart for our audience?
Well, as anyone in practice knows, bipolar disorder is relatively common, and depression is the most common mood episode associated with bipolar disorder. We see it all the time, but sometimes it goes under-recognized if we have not identified a past history of hypomania or mania. So that's going to be really important to do. We also need to be cognizant that treatments for major depressive disorder, unipolar depression, such as SSRIs or SNRIs, can actually make bipolar depression worse. We have 5 FDA-approved treatments for bipolar depression. In the past 20 years, we've made great advances here. All of them are second generation antipsychotics. Some are also approved for bipolar type 2 depression, and some are also approved as monotherapy or adjunctively with lithium or valproate. And all of these choices are far more useful and safer and result in better outcomes than using SSRIs, SNRIs, or NDRIs, mentioned those too, when treating bipolar depression. So I would gravitate towards what's been tried, tested, and true.
Again, thank you very much for sharing your clinical and research wisdom for us. So at this point, I'd like to conclude the second episode of our podcast. Again, thank you very much, Les, for joining us. And I also wish to thank our audiences for participating. And I hope they found this information useful. Thank you very much.